I want us to shift gears and have a conversation around fertility and what you can be able to do in case you've been asking yourself questions. You have been on this journey trying for a child and it has not been possible for you probably, and the concerns about technologies, key among them is the in vitro fertilization, commonly known as IVF. I have experts in studio who are going to be shedding light on what needs to be done. Just to run you through who I'm hosting this particular morning, on my far right, I have Dr. Shonak Kandwala. He's the director, Fertility Point. Thank you so much for creating time. And we have with us this morning Dr. Rajesh Chowdhury. He's an IVF specialist and also a consultant. Thank you so much for creating time as well. All right, so I want us to begin straight away and just to be able to understand some of the main causes of infertility. I'll begin with you, Daktari, just to help us understand the most common types of infertility and just break it down for us, for people to understand in case they are in that particular situation.
Yeah, good morning. Thank you for having me here. So there are before we go into the causes of infertility, I would just like to point out one fact, that infertility or the lack of fertility is a relative term as well as an absolute term. So you can have full infertility or there can be a relative infertility where a woman goes on conceiving but she aborts, or she may have conceived earlier and then does not conceive later on. Also, I think fertility or infertility is a reproductive choice of the couple rather than a condition or a disease. So we need to respect that also. And then, of course, infertility has to be managed if it gets out of proportion, or if a couple does not have a child after having 1 year continuously together, having frequent intercourse, not using contraception. So that is actually a definition of infertility. Okay. And then coming to your main question, that is the causes of infertility. The causes could be in the male, in the female, in both. And there are some infertility types where there are no causes either in the male or in the female, which is called unexplained infertility. So the causes, maybe in the male and the female can be broadly divided or classified into genetic, acquired, that means it comes in this, and then there is environmental and stress. So the causes, the most common cause of infertility in a woman is pelvic inflammatory disease, which causes tubal blockage, or a uterine factor like fibroids, or intrauterine synechia, which means adhesions within the cavity of the uterus following a very bad miscarriage or an abortion, causing infection within the uterus. And ovarian factor like a polycystic ovary or a premature ovarian insufficiency, which causes anovulation and therefore no ovulation. Anovulation is lack of ovulation and therefore no egg coming out and therefore no pregnancy. And in a man, it is mainly reduced sperm count, what we call as oligospermia, or reduced motility of the sperms, which is called asthenozoospermia. So it's oligoasthenozoospermia, high abnormality in the sperms due to genetic factors or acquired factors, environmental stress, everything plays a part. And very rarely, not very rarely now very commonly, we have azoospermia or absence of sperms in the semen. So these are the general causes that we come across.
I'll come back to you so that you can at least shed a bit of light on especially reduced sperm, what could cause that. But before we get to that, I just want to also rope you in, Rajesh. Tell us a bit about when should a couple be concerned? When should they go to a clinic to get checked? Because most of these cases, we understand, come at very late stages after they've tried even for so many years something that could have been corrected earlier. So what stage should the couple come?
I mean, when the couple have been trying for a year without any protection, then they should seek advice from a doctor. Now, when they should seek advice, that depends on the couple age, the woman age. If the woman age is less than 35 years, then they should give themselves a year time before they seek advice. But if the age is between, say, 35 to 40, then they should give a time of 6 months. But if it is more than 40 years, if the woman age is more than 40 years, they should try a few months. They should not wait for 6 months even. And if there is any pre-existing conditions, like any endometriosis or any previous history of surgery, pelvic surgery, then they should not wait. Like they should seek the fertility doctor before.
As soon as possible.
As soon as possible.
All right. So if you look at the trends, do you see people coming in late, more people coming in late, or there is a trend whereby couples are increasingly becoming aware these days? What are you noticing as experts?
Yeah, they do come often a bit late, I mean, too late, in fact. What we have observed in our clinic, mostly 50% of the patient, they come after 40 years. And some may have second relations, like remarriage. So they should come early because the age affects the fertility. The fertility declines with age. So they should come to the clinic as soon as possible, and they should consider having children when they are young, because the egg quality declines after the age of 32 years. That is proven scientifically. Yes.
Yeah, the
yes.
lower the
and
quality.
with age, there is other factor that develops. There is other conditions like fibroids, endometriosis, diabetes, hypertension. That will further complicate the process of pregnancy.
All right. Dr. Shaunak, how do you assess, when a patient walks into your facility, so how do you assess, what are some of the things they should expect, during the examination, what is done, and what are you looking at, to determine, their status?
So see, every couple who comes to our center or clinic does not require to do IVF. There are many other modalities of treatment that we can do. But in order to know whether what to do, we need to have a complete and a proper history taking. So, we need to know exactly what the couple has as far as, their past history, present history, what are the complaints, what else is there. Then we start doing the assessment of the female and the male. So we get a rough idea. But, at our center now, because we are so well known for IVF, generally when a couple comes, it's usually for IVF. So, we don't, we usually...
So they've tried all these other
They've
options?
already tried, yeah. That's the other thing I wanted to point out when you were asking him the previous question, that they go on trying so many things which is not really good for them. So that, and by the time they come to our clinic, so many things have been done, like ovulation induction, which has actually reduced their egg count. So by the time they come to us for the IVF, half the battle is lost. So, it's very difficult for us then to restart the whole thing and then get the woman pregnant. But anyway, so when they come, we do the history taking, we see what is the possible factor, and then we start doing the investigations. So there are tests for the female and there are tests for the male partner. So these tests can be divided into an imaging means radiological tests, blood test, that is hormonal tests, and then of course in the male partner there is a semen examination, which forms the cornerstone of the diagnosis for the man. But for the woman, we can do ultrasound, we can do what is called as a hysterosalpingography, which shows tubes are blocked or they are open, and we can see the uterus also. And then if you want a higher diagnosis, if there are fibroids or whatever, then we can do a MRI of the pelvis to see further. Similarly, in a man, if the counts are very low, as I was telling you earlier, or even zero count, we can also do hormonal studies and an ultrasound of the scrotum or the testis to see if there is any testicular problem or if there is something called varicocele, like that.
All right. Let's talk about this IVF. We may assume that people know what it is all about, but guys are very curious and they want to know how it works and what are the chances of success. So let's get there, because your facility majorly specializes on IVF. And I'll come to you, Dr. Rajesh. Just break it down for us in simple terms. IVF, how does it work?
So there are certain indications for IVF, like very low sperm counts, where even IUI cannot work. I would say if there is a tubal block, where only way to get pregnancy is IVF. I would say if the IUI is failed, 4 or 5 attempts of IUI, traditional treatment is failed. When there is a problem in ovulations and it has not been successful with other treatments. So there are few indications for IVF. So once the couple is there and then IVF is decided, then we do certain test that is called pre-IVF workup, which will include a certain blood workup before IVF and certain pre-IVF medications and certain lifestyle modifications. The whole idea of doing this is to optimize the condition so that the chances of IVF are increased.
The success rate is increased.
Yeah.
So this is done before even the actual IVF is done. So how many months of preparation?
That depends. Like sometimes when the woman is overweight, so we give a bit chance, like 1 or 2 months to cut down the weight. Sometimes even reducing the weight can improve the ovulation chance, right? Now, there may be some nutritional deficiencies, like iron deficiencies. There may be, so we give some multivitamins and sperm boosting and egg boosting medicines. There may be some surgical reason that can impede the chances of IVF implantation, like fibroids. So if the fibroids are there, that is indenting the womb lining, then that has to be removed first. There may be a polyp in the endometrial cavity that has to be removed before doing the IVF.
All right.
Right? So similarly, the sperm count may be too low. So we give some sperm boosting medicine that can improve the DNA of content of the sperm so that the embryo can come good. So roughly 1 to 3 months is good enough. But there may be a situation where we may not be waiting for the IVF process, like in cancer patient or some those who are traveling abroad. So these pre-IVF workup are done. So once that is done, then we generally start the IVF starting from the second day of the cycle.
All right. Actually, let's talk about, those who don't have children not because of they can't, but because of choice. Yeah. For instance, those who are in career and probably they want to, be in charge of when they want to have children. So let's talk to us about whether this is something also you are noticing from the traffic that is coming to your facility, and what are you doing in terms of, just also helping couples out there to decide when they want to have children.
So I wanted to get one thing straight. IVF is a general term which is called in vitro fertilization, but the actual fertilization process that we use and what most of our patients also know about is what is called as ICSI, or intracytoplasmic sperm injection, where we inject one egg with one sperm under a high magnification in the microscope that is done by our embryologists. Okay, so
that's done externally.
That is done in the lab. So that's why it is in vitro. In vitro means outside the body. In vivo is inside the body. So in vivo fertilization is the natural conception. But when it's done outside the body, the fertilization in form of ICSI, it is called in vitro in the lab. Or what was generally called earlier as a test tube baby. But it's not actually a test tube, it's a petri dish in which everything is done. So actually it's a petri dish baby. Anyway, so coming to your question regarding... there are so many options available for such couples who want to not actually have the pregnancy. So there is something called elective freezing or elective freezing of their gametes or embryos. So let's say a lady is there who's a career woman who wants to set up her career first and then think about pregnancy, or she has not yet found the right partner. So she can go for elective freezing of her own eggs by the same process of IVF. So only the initial part of the process is done. That means her eggs are retrieved after doing ovarian stimulation, and these eggs are then frozen by a process called vitrification or cryopreservation. And these eggs can remain frozen for 5 to 10 years before she decides to come back for the pregnancy, if she does not conceive naturally when she has a partner. So she can use that partner's sperms to fertilize these frozen eggs at a time when she might not be able to produce those many eggs. So, if she's 5-10 years ahead, and then the fertility status, as Dr. Rajesh was saying, with age declines of a woman, she can still have those eggs to be fertilized. Similarly, the man. So, there are so many men who would want to preserve their sperms, but I think it's more in a woman that they want to preserve elective freezing than in a man. Because a man sperm count and all does not decline so rapidly as a woman's would, with age. So it's
most common among women than men.
Yeah, because the age is a very deteriorating factor for a detrimental factor for a woman more than a man. As far as fertility is concerned.
All right. I want us to get to the IVF treatment. How long does it take and what are the steps? Now, assuming all the tests have been done and the candidate is suitable for IVF, you've taken the time for pre-planning and you've done all the necessary surgeries or whatever that had been recommended. So now it's to the stage of IVF. So how long does it take and what are the steps somebody should be expecting?
So roughly it will take 4 weeks, right from the starting the IVF injections to the pregnancy test. So once all the pre-IVF things are done, we call the couple on second day of their cycle, second or third or fourth day of their cycle, and then we do ultrasound, baseline ultrasound and blood test, hormonal test if required, and then we start the IVF injections from there. Right, so the IVF injections go for like 10 days, plus minus 1 or 2 days, depending on the individual eggs, how they grow with the IVF injections. So roughly 10 days of IVF stimulations. In between these 10 days, the woman has to come 2 to 3 times to get monitored by ultrasound and blood tests to see how the follicles are developing. So once the follicles are developed, matured by ultrasound, then we give a final injections on the night, and then after roughly 36 hours of the final injections, we plan for egg retrieval, egg harvesting. So that could be like 12 days of the start of the injections. So on the day of egg harvesting, the husband has to come as well, if possible. If not, we generally freeze their sperm, right? So that if they're not able to come on that day, so we can use that frozen sperm. So on the day of egg harvesting, they have to. It is a very minor procedure, like 10 to 15 minutes of procedure done under the anesthesia. So after the procedure, within 2-3 hours, she can leave the facility, right? So it is just a daycare procedure. It's not like a big operation, right? So once the egg is harvested, on the same day, the egg is injected with a sperm through a very fine needle. That what we say is ICSI.
She doesn't have to be there.
She doesn't have to be there. Now the egg harvesting is done in the operation theater, and all this process of egg and sperm are done in the embryology lab, where the embryologist takes over then, right? So once that egg is injected with the sperms, then they are kept in an incubator, and the next day it is checked whether it got fertilized or not. And then every 24 hours it gets checked by the embryologist about the growth of the embryos, right? That egg. Now that egg, once fertilized, is supposed to be embryo blastocyst after 5 days, right? So the embryologist will then grade the quality of the embryo. And generally, we freeze these embryos, and we transfer these embryos in the next cycle. I mean, generally, when it is not indicated to do the transfer freshly. But if the fresh transfer is done, then we do the embryo transfer after 3 to 5 days.
3 to 5.
So we select 2 to 3 good embryos, if it is day 3 embryo, and generally 1 to 2 blastocysts, if it is done after 5 days.
When you're doing the egg harvesting, you harvest just quite a number.
Yes.
Just one.
Yeah, it's like a pyramid, you know. If we get 20 egg, not all egg will be mature egg.
Right.
So generally 80% will get mature. Like out of 20, so 15 will be mature. Right. So only mature egg can be fertilized with a sperm.
Let's talk about more, just pick up from where he has left, what you do to increase the chances of success, because let's say the truth, it's not a cheap affair. So we want success rates to be high. So what do you do to ensure that there are higher chances of success? And the other question is, can the couple choose the gender of their child, or whether they want to have twins or not? Are those possibilities that are there when it comes to IVF?
Right. So, you know, the first IVF baby was born way back in 1978, and we are now almost 50 years hence. But still, we haven't yet achieved 100% pregnancy rate. You know, so the cookie crumbles that way. Yeah. So it's about 50 to 60% at our clinic. That is the clinical pregnancy rate. The take-home baby rate would be, that is a live birth rate, would be 30 to 40%, because all women who conceive with IVF do not go through full term. There is premature delivery, there is miscarriages, you know, along the way. So that's an unfortunate part of the treatment. But of course, in order to increase the chances, as Dr. Rajesh was saying, the steps of IVF, so I tell all my patients that the number is a very important, it's a number game, you know, the IVF. Number game and the clinic you come to. So if the clinic is lucky for you, then you will have good success rate. But at the same time, the clinic has to do something to be lucky for you, right? So we have so many other add-ons besides IVF. After doing the fertilization, we have something called laser hatching. So we hatch the embryo wall. When they are frozen embryos, when we do the frozen embryo transfer, we make a small laser point on the embryo wall so that it hatches when it goes inside. Because ultimately the embryo implants at day 5, so which is called as a blastocyst. So we do a blastocyst culture also that improves the pregnancy rates after fertilization. And then, you know, artificial intelligence is coming everywhere in the world, in all fields. Similarly, in IVF also. So artificial, you know, when we upload these images of the embryos to a computer and the artificial intelligence scans among its vast database, it tells us which is the right embryo to transfer. And we have what is called as also real-time imaging or time-lapse imaging. So every day, without removing the dish, you can see how the embryo is progressing from day 0 up to the day you are doing the transfer.
All right.
And then coming to the second part of second question that you said about balancing, we do what is called as PGT, or preconceptional genetic testing. So all these embryos at day 5 are biopsied. That means the part of the cell of the embryo is removed and sent for genetic testing. And the genetic testing gives us the chromosomal pattern.
All right.
So from the chromosomal pattern, we can make out which gender this embryo is.
So you can decide
which one to transfer depending upon what the couple desires.
Okay.
But at the same time, you have to also understand that, let's say a couple desires a female child. So you can get a female embryo, but it may be abnormal, you know, because the chromosomal pattern also tells us about the normal and abnormal, that is euploid and aneuploid. So if it is abnormal, you're not obviously going to transfer, even if it's the gender of choice for the couple.
All right. At what cost implication? Let's talk about that. And whether it's covered, you know, concerns about whether this is covered in insurance. You know, let me start with you, Dr. Rajesh.
The roughly cost, it depends on the clinic to clinic, but in Kenya, it's roughly around 400,000 to 500,000 per IVF cycle without injections, right? Now, injections depend on the ovarian reserve of the individual. Now, if it is a good ovarian reserve, then even the lesser injection can produce a good number of egg. So that means you can take like 100,000 on an average for the injections. And some pre-IVF workup will require, say, 30 to 40,000. So you can say like by 600,000 should be the budget. But it
That's
also
approximately.
But if there is a variation in the treatment, like if there is a need of donor egg or donor sperm, then that cost will go a bit high. And if you desire to have a gender-specific child, like doing a gender selection IVF, then it can go even higher.
What if you do the first IVF and it doesn't go well? Do you pay again the roughly 600 or?
No, it all depends upon how the IVF, how many embryos you have been able to create. So let's say you created 10 embryos. You won't transfer all of them into the uterus, right? Yeah. Because you will transfer, at our clinic, we transfer 2 embryos at day 5 or 3 embryos at day 3, which is good enough to get a pregnancy, at the same time not have high order multiples. That means not have triplets or quadruplets. Though once in a while we get triplets, it doesn't always happen. And the remaining embryos, that is a surplus embryo stock, we can freeze them for the future.
All right.
So at 50% of the cost of the first cycle, she can do a second cycle. She can have a second bite at the cherry without going for the full thing again.
All right.
But it's not always that everybody gets a frozen embryos. Everybody doesn't have a surplus embryos. So in those cases, then we charge them again, but they don't have to pay as much. They can be discounted to a certain extent.
All right. We've come to the end of this conversation, so 30 seconds each for your final words. Let me start with you. In case somebody has been watching, they are curious, they have questions, what do they do?
So, you have to understand one thing, that IVF is physically, emotionally, and financially draining procedure for the couple. So it is very important to include in the package, as we have in our clinic, a genetic counselor, a psychological counselor and a genetic counselor. A psychological counselor will allay all the fears and the anxieties and the nervousness of the couple, at the same time give them hope, in addition to what the doctors would do. So that is very important for to have a psychological counselor too, because she or he can talk as a friend to them and not as a professional as we talk.
All right. Yourself?
Yes, if someone is curious about knowing the IVF process and going for that process, one should do enough researches and find out a good, appropriate clinic and doctor, and can take second or third opinion as well, and then select a good center to go ahead for the treatment.
All right. A good center, Fertility Point, of course, one of them, you've just given us information about what to expect during this particular process. I have been having this conversation with Dr. Shonak Kandwala, Director, Fertility Point, and of course, Dr. Rajesh Chowdhury. He's an IVF consultant. Thank you so much, both of you, for creating time for us. And that's how we wrap it up. But remember, we have been following up, the Go Slow at JKIA. And I want us just to cross over back